So, thank you, Simone. It's really very gratifying to see so many faces in the audience, patients. That's what we're here for. That's what we're about. Over the last 2.5 days, you've been at the forefront of our thinking and our discussions about how we can provide better patient-centred care and address the needs of patients. And it's really been an honour to have such a fantastic faculty here. It's a testament, I think, also to the work that's done in this region that we were able to recruit to this meeting really world-leading experts. We asked a very, very select few people to come, and we had 100% acceptance. No one refused our invitation to come to Australia to be involved in this meeting, and so we're very proud and privileged to have them. And so I'm going to call each of the All-Star team up to introduce them to you one by one. The first one is Dermot O'Toole. I think Dermot was here. There he is. Dermot's coming down from the back. Dermot's the current president of the European Neuroendocrine Tumour Society. This has really been the driving force for many of the guidelines and many of the advances that have been done in the neuroendocrine field. Dermot's been an integral part of that over many years, and also has been a driving force for what's called the Centres of Excellence network through Europe. And I'm very proud that my team was accredited as a European Neuroendocrine Tumour Society Centre of Excellence this year, which is really a great tick of health, I think, for what we're doing. But it's really a fantastic program which has built quality into the systems. And when we first looked at it, I think 4 years ago, Dermot, we were sort of scared that we weren't actually doing as well as we thought we might be. And we had to lift our game to actually get accreditation. And that's really what the ENETs COE network is really about. I think the next person on there is Halfdan. Yep. Halfdan Sorbye is led really practice-leading changes in the management, particularly of high-grade neuroendocrine tumours. If you think neuroendocrine tumours as a group are rare, the high-grade ones are rarer again. And we really haven't had very much data to tell us how to manage those. And Halfdan's group, the Nordic study, was really one of the really important pioneering studies to give us some clues that perhaps even within that small group there are differences, and these have been practice changing, and he's been a great advocate as a medical oncologist of innovation in the area of these high-grade tumours in particular. Next, I think, is James, is it? Michael. Michael Michael's my co-chair of the ENETs Centre of Excellence. Over many years, he's been a great support for the program. You don't build any of these things without great collaborators, and Michael has been a fantastic resource for our patients. He's a very giving person. Many of his patients, he'll take emails, phone calls any time of day. That's right, isn't it, Michael? I only hear good things about the care that he provides. Who's next? Simona. Simona's an old friend, a young old friend. I mean, old in the in the nicest possible way. She is again a wonderful person. Comes from Jerusalem. In Hadassah University, we've had some wonderful collaborations. She's an endocrinologist, so she's going to be available to answer some of the questions about the difficult aspects of this as a disease, not only as a cancer, but also as a hormone-secreting tumour that gives a whole raft of syndromes and symptoms which are not related necessarily to the cancer, but to its function. And so it's great to have Simona here. Next is Professor James Yao. James is a medical oncologist as well. he's also something of a computer nerd. I think started as a computer nerd and then became a doctor, which is usually the other way around. But as well as very seminal studies that he's led out of MD Anderson in the US, really, again, practice-changing work, particularly around targeted therapies, but going into very basic science. He's also done an incredible amount of work with databases available in the United States to understand the prevalence, the growth, and how this is evolving and how survival is changing over time. And that's been really important politically to get interest in this disease and to get resources into it. He's been a leading light in ENETs, the North American Neuroendocrine Tumor Society, and really is one of the giants in this field, and to have him here is really a great privilege, as I said. Ben Lawrence, Unicorn New Zealand, is very blessed to have an advocate clinically for their activities in Ben. Again, he's an old friend. I can say that you're a bit greyer than Simona, but not quite as grey or as bald as me. Certainly not as bald. But Ben is also a very good friend of us here in Australia. We've had a wonderful relationship over the years, and Ben's one of the world experts on the genomics, the genetic drivers of this disease, and we're going to have a discussion, something about genes and how they might be involved in the future. And finally, the youngest, prettiest and smartest star in the team is Grace Kong, who's one of my team. She's a nuclear medicine physician. She was the scientific coordinator of this meeting that we've just held over the last couple of days. She did a wonderful job. I'm sure that all the international experts came because of her arm twisting, and she's done a great job. So she's going to talk a little bit about some of the nuclear medicine aspects that I'm sure that you're interested in. So I'm going to pick up a few of the themes that Simone raised, where us doctors don't have a clue really about what you want. We're trying to understand there's this big gap, but those three areas are around the multidisciplinary approach to cancer and how well we're doing in that, in delivering on your needs, how well we convey the current evidence about what's available in terms of clinical trials and new knowledge about the disease, and finally about genomics. So we're going to start with the multidisciplinary approach. And so what I'd like to do is go from the far end to the near end to perhaps ask each of the team how a multidisciplinary panel works in your particular institution. Just a brief overview, who comes, how it's run, how many patients are discussed, whether every patient's discussed, and so forth.
Yeah, thanks, Rod, and it's really a pleasure to be here among you this afternoon. I've had a great time for the last few days and learned lots, so lovely to see you all, and welcome. So we have this multidisciplinary approach, and we call it, or the tumour board is the other term that we use for this, where we try to get all of the experts together that may be involved in looking after the patients who come with a new diagnosis. All new patients, in fact, are mandated to be discussed, all new patients. So we'll get a referral through maybe the intranet, or through, it might be a text to one of the key team members, or a formal referral through a letter. And what happens is that our net team coordinator, who in our group is a nurse with an administrator, they will contact us and we say this is suitable for our next tumour board meeting. And we try to have the discussion for the individual patient on a Friday morning, every Friday morning with us, and we try to see the patient then on the same Friday morning if possible, because it's all fresh in our minds. What happens is that I'm a gastroenterologist, but I'm also the NET coordinator, so I'm involved in sort of leading the team with my co-worker who is an endocrinologist, and we have to have a fixed number of people involved, a quorum of individuals. That includes general surgeons and hepatobiliary pancreatic surgeons. They may be involved with pancreatic neuroendocrine tumors, we have to have the radiologist, we have to have the nuclear medicine specialist to interpret some of the scans that, I'm sure Grace will talk about that in a minute. And we obviously have to have the coordinators there as well. The pathologist is the vital thing, and that's where we start. After seeing the radiology and listening to the story of the individual patients that will be described, we then go through the various other components, the radiology, and then we go through the nuclear medicine scans, and then we go through the pathology. And we try to get then an overall picture of what an individual patient may come with, for example, a small intestinal neuroendocrine tumor, classical carcinoid tumor with somebody with flushing and diarrhea. So we learn about the symptoms, then we try to map the symptoms to the imaging and also to the pathology. So we get a snapshot and we will have a look and sort of try then to piece that all together to come up with adequate diagnosis and to come up with a therapy plan. Sometimes the patient will have been seen in the clinic beforehand, or they may have been seen in one of the specialist clinics, but brought to the tumor board. And then on the strength of the information gathered around that individual patient, we will try to tailor therapy for that individual patient, see the patient and their family, and discuss then how the symptoms, how that's affected them, and come up with a therapy plan. So that's a bit in a nutshell. It sounds pretty straightforward, but it actually takes a lot of coordination, a lot of time. The tumor board usually lasts about 2.5 hours. All new patients in our group and in the European Centre of Excellence models are mandated to be discussed. And in our group, we try to discuss all changes in therapy. So if somebody is, for example, has been stable, been very well, and let's say they just come through for a CT scan or a gadolinium PET CT scan, a gatate scan, as you call it here in Australia, and everything's stable, they'll still be discussed at the tumor board, but we may not have to go back through everything again, like the pathology may not have to be rediscussed, and we're happy we're in that situation. But a patient who comes and they've got worsening diarrhea or symptoms or shortness of breath, or they've got some weight loss and they've got some signs that they may be progressing or there's something else going wrong, well, then it will be discussed in far more detail. We'll go back through individual things, so you can see if it's more complex, it'll be taking more time, and that's really, really important. And again, they're rediscussed. Some patients who live a little bit far away, we may not bring them back to the clinic on that day. We'll give them a call. So we've got a sort of, just like you would have here, either a web-based consultation or just a teleconference consultation with the patient afterwards. At the end of our clinic, when we see the patients live, we call those to go through either with their nurses or with their local team, but also with the patients, because they want to find out where they are. So I know there would be different sort of variations of that in different groups, but more or less this is the way in most of the sort of tumor boards and the discussions around the multidisciplinary team will take place. But as neuroendocrine tumor numbers of patients increase, then of course you'll get everything happens on a Thursday, but very often now we've got a Monday evening, we've got a problem, etc. So there's a lot of interaction then between the NET specialists who attend the tumor board, the radiology, nuclear medicine, etc., outside of that. But the main activity more or less takes place around those specific focused meetings that we try to dedicate to your care.
So Halfdan, you've got fjords and snow and elk in the way. How does it work in Norway?
It's probably something, distances are quite far for patients, but I think we do it quite similar. The main thing is when we have this meeting, every patient is discussed individually, and we make sure is the diagnosis really correct? Are we certain the patient has a NET or not? Have you done every examination that we should have been doing? And then the vital discussion is with the surgeon. Can we operate on this or can we not? Which is a major decision. Usually decide that at the meeting. And if he can be operated, he will go for surgery. Otherwise, we will have to plan him for other therapy. And we know that this waiting time is very heavily on the patient. So we usually have a very early appointment with the patient. And we have specialized nurses who attend to that meeting. And then we make a plan for the therapy. And then we try to start therapy as fast as possible. And the patient will also have a contact with the nurse and can phone her for further questions. So we have to make sure that diagnosis is correct, the treatment is correct, and we start as fast as possible.
Michael?
It's very similar. We'll have initial patient contacts, often through myself or Rod, for example, and then we'll have it processed by our specialist nurse who will make sure that we have all the information together to be able to discuss the patient at a multidisciplinary meeting. If not, we'll sometimes see the patient before the meeting and organise those investigations. So when we come to discuss the patient at the meeting, everything is there for us to make an informed decision about the potential treatment plan for that patient, whether it's observation, whether it's surgery, whether it's some form of treatment, hormonal therapy, PRT, for example. And we have two multidisciplinary meetings, one's particularly for NET patients, and then a separate one for discussion of patients for PRT, where patients that are being referred for PRT, or if they're having had PRT and in follow-up, we'll discuss those patients and determine how they're progressing. Is PRT appropriate? What should we do with these patients? And which aim to try and see the patient as quickly as possible within 10 days of referral, unless there's some outstanding investigations where we'll try and get those done first. But similar structure, we have pathologists, nuclear medicine physicians, radiologists, surgeons, specialist nurses, dietitians, nuclear medicine physicians. We'll have endocrinologists involved as required, or cardiologists, etc., depending upon the need.
So I guess this is one of the first areas where our patients can really help us by being advocates for their own care and nagging their referring clinicians to send us the results as quickly as possible, or if possible, get it in your hot hands and bring it along yourself. It's one of the great frustrations I think that we all have, is the delay between the referral and getting all that information in our hands to make the connection. Simona?
First of all, it's really amazing to be here and to see that all of us have the same problems, doesn't matter where we are in the world. And it's really important to collaborate. And sorry. So I was saying that it's really amazing to be here for me and to see all of you, and practically to see via you all my patients, and to feel that we are the same community dealing with the same problems, and doesn't matter where in the world or in the globe we are living. So practically we are doing quite the same. Usually we are seeing the patients before the multidisciplinary meeting, and we are trying to do a revision of the pathology. We have meetings to do revision on the CT, on the imaging, on the gallium dotatate, and to be prepared to present the patient and to take the right decision during the meeting. Usually we have these meetings about every 2 weeks, but sometimes it depends on the urgency, so we are doing small meetings every day practically.
James?
Yeah, so in terms of physician involvement, it's quite similar. We have 3 medical oncologists that see neuroendocrine tumor surgeons. Pathologists attends the tumor board, as well as radiologists and nuclear medicine. What's a little bit different is that we don't actually present all cases. That's probably a volume issue. We see probably about 450 new patients and have about 2,000 active patients in our practice. So we mainly discuss cases that require multidisciplinary input, or there's a certain dilemma, or review specific scans and so forth.
Ben?
So I'm a medical oncologist in Auckland. It's great to see you all here, and we have a sister organisation called the Unicorn Foundation New Zealand, which do an amazing job of advocating for our patients. We have New Zealand works that we have 6 cancer centres, and that's across 20 hospitals. In the hospital I'm in Auckland, we have the only neuroendocrine multidisciplinary meeting for the country, and that's video linked to all hospitals in New Zealand, so any physician or any doctor anywhere can video link in and present their patient. It's optional for the physicians who are looking after those patients, so some people, that causes some problems, because and many times the doctors who are quite good at looking after neuroendocrine tumours know what they don't know, and so they present, whereas the doctors who perhaps don't know what they don't know don't present, and so that's something that we're kind of working on. We have 3 pathologists who are probably the heart of our MDM. I think that if you were to pick who you're going to have at the MDM, I'd pick a pathologist, not a useless oncologist. You know, we do a bit sometimes, but a pathologist gets the diagnosis right, which is the critical, that determines the path of everything that will happen from that point. When we first started our
As long as I know where to biopsy and what to biopsy.
That's true.
It's imaging.
Maybe that's going to be the next discussion. Pathology. So when we first started our multidisciplinary meeting about 3 years ago, what we found was that about 30% of the cases were reclassified in some way pathologically, either a change in grade or a change in the Ki67, which is how aggressive the tumour is, or it wasn't a NET, or it was a NET, or it was a mixed NET and something else. So it made a huge difference. But once pathologists around the country knew that we were going to be checking their cases, they got a lot better, and it's actually reduced down a lot. We meet every week, so we have 3 pathologists, 2 radiologists, one of whom's a nuclear medicine specialist, and they either present together or tag team if one of them's on leave. We have 2 hepatobiliary surgeons, so that's the upper part. They can also cover the rest of the body somewhat. 2 medical oncologists, that's our core, and then we have a group of others, lower GI surgeons of the bowel, and radiation oncologists who come and go a little bit. We don't have PRRT in New Zealand, and we don't have funding for it either, so patients who can afford it fly to Peter Mac for their treatment with Rod and Grace, which is really tough because it's super expensive as some of you may know. So that's something that we're working on, and probably early to mid next year we will have funded PRRT in New Zealand, so it'll be a big step for us.
So Grace, Michael alluded to there being 2 kinds of MDTs in Peter Mac. Can you explain why there are 2 and how they interact with one another?
Yeah, sure. I mean, they're very, very interactive MDMs. So I work with Michael, so we attend the same MDM. So we have 2 MDMs at Peter Mac. So every Monday morning we have a NET or PRRT MDM where we would predominantly talk about patients referred to us for PRRT or for medical treatment, or we would discuss new patients or patients who come back for follow-up, scans or with particular problems. With that particular MDM, basically, is attended by all the nuclear medicine physicians, and within our team, we have about 6 of them. It's well attended by several technologists who are heavily involved with the radionuclide therapy program. The nurse coordinator, Meg Rogers, usually comes to that meeting, and obviously medical oncology team where Michael leads, and a few other medical oncology colleagues as well. So it's a very medical, we discuss medical issues and PRRT issues. But every Wednesday we have a separate MDM, and that is called an upper gastrointestinal multidisciplinary meeting, where it's represented by myself from the nuclear medicine perspective together with Rod, and a bigger medical oncology attendance together with a pathologist, as well as a few very experienced upper gastrointestinal, so upper bowel surgeons, and they're not able to attend the Monday morning MDM. So all the complex cases that would need surgical opinion, where we need to pin down the surgeons to see whether they can operate or not, we would discuss all those complex cases on Wednesday, as well as all the pathology reviews to make sure the pathology is right. So we have a pathologist who can review all the slides in that particular MDM, but they're not mutually exclusive because patients can be discussed on the Monday. If we feel it's too complicated for the Monday, then we move the patient onto the Wednesday MDM for discussion. But I think just an extra point, Rod, I think from the nuclear medicine perspective, it's very important that we review all the images for new as well as patients coming back for ongoing follow-up, because as you know, GAT8 PET scans and FDG PET scans are now becoming more widely available, at least in Australia. Some patients have scans with us in Peter Mac, which is great, but because it's becoming more available elsewhere, a lot of people actually have scans done outside Peter Mac. But often just reading the report is very difficult to interpret the real findings, so we would always like to actually look at the pictures on screen to make sure that everything matches clinically and with the pathology as well.
So James, there's a lot of brain power in those rooms, lots of people, and my administrators would say a lot of underworked and overpaid clinicians. Why do we need so many people in the room? What is it about this disease that requires so many people?
Yeah, so neuroendocrine tumors, different than many other cancers, there's a huge, I would say, heterogeneity in terms of outcome and as well as how aggressive the tumors are and so forth. And also, the neuroendocrine tumor, unlike many other tumors, can arise through a variety of sites throughout the body. Everything from the lung, where a thoracic surgeon may be needed, to GI surgery, hepatobiliary surgery, and so forth. So, I think the imaging expertise is also get very subspecialized in large centers. For example, we have people that essentially only read abdominal imaging, other read chest imaging, and other only do nuclear medicine. That's the reason you really want a lot of expertise in the room.
Okay, Simona, we had a mock MDT here a couple of days ago, and it got a bit gritty between you and one of the medical oncologists about which treatments to use. I alluded to the fact that there's these two aspects of neuroendocrine tumours, the potential for them to have hormone-related symptoms or secretory symptoms, and the oncologic condition. So how do you balance those two needs in terms of patient care? Sometimes when the treatments for one are not necessarily compatible with the other.
So this is one of the many important questions that we are practically discussing in the MDT. You know that most of these tumors are not secreting hormones. However, about 25%. They may hypersecrete hormones that can produce different symptoms such as diarrhea, flushing, increase the blood glucose, produce a rash, and so on. Usually we are discussing, depending on the situation of the patient, the age, the background, the availabilities of different treatments. And we decide together. Sometimes we fight, but I'm an endocrinologist, so usually we're very conservative. But sometimes I'm more. I find myself more, in a fight with the surgeon to take out the tumor, or to do debulking. Debulking meaning to take part of the tumor out of the body when we cannot control some symptoms, for example, in a patient with metastatic disease. So it is really a complex matter and a complex issue to deal with these tumors, but usually depending what is bothering the patient the most, and depending on the levels of the hormones, so we decide sometimes to start with medical treatment, sometimes to go for a local regional invasive treatment to the liver. Sometimes we decide immediately after starting somatostatin analogs, for example, to do a valve replacement if there is involvement of the heart.
Yeah, so I think you put it very nicely. It depends what the patient wants. And so one of the things, I guess, that we always want to put back to you as patients and carers is to start to prioritise what's really important to you. Have a list of things that are really diminishing your quality of life, or whether duration of life is the thing. Is there some key event in the future that you want to get to that becomes, managing the oncologic aspects of the disease may be more important necessarily than symptoms. So everyone has different priorities, and it's very important, I think, for patients to start to think about that and talk about it with their families, with their carers. What are the priorities in care? How do you judge a successful outcome of the treatment that we're delivering? Because that's what informs our discussions. And sometimes we have these discussions, in isolation without that knowledge. And then we make maybe decisions which may be right on evidence, but wrong for you as a person. So it's very important that you, as a group, start to articulate and communicate, and also for us to listen to those messages. I think it's very important. Dermot, your ENET Society has been really actively involved in developing standards of care, treatment guidelines, investigation guidelines. How important is it to get international uniformity, synchrony between those different guidelines, and how can multidisciplinary teams help in that process?
Yeah, I mean, I think that just following on from the point. I mean, I think that if we went through the various patients and families here, we always have these stories of how long it took to be diagnosed, how long it took to get treated, and what we want to provide as a society, as a net society, but also have in our society is that every patient with a neuroendocrine tumor, just like, Halfdan, you've been involved in other types of cancers as well, but we have access to specialty care. I mean, that's got to be the priority of a neuroendocrine tumor society group, and the idea of having access, I think, is the number one question. And then having access to expertise is not just one expert, it's the group, like we've just described. There's this multidisciplinary group, the tumor board that looks after the individual patients, of course. This tumor board will stay up to date because we come to meetings like the one that Grace and Rod and Simona have just organized. So we're staying up to date with new innovations by people like James, by Halfdan, by other people in terms of PRT or chemotherapy or innovations even in surgery, etc. So the idea that we're up to date with what's available. We'll talk about what needs to become more available as well, because in fact we need to be more proactive in that area. But I think access to high quality care is what our European Neuroendocrine Tumor Society was what it was about 10 years ago when we set up this, we call an international standard of care program, where we're creating this sort of center of excellence model. And we created this program whereby centers had a chance to come in and learn about how we try to have a homogenized or uniform way of dealing with patient care, all of the diagnostics, all of the therapeutics, following guidelines, and as close as we could to what we call international benchmarks, okay, the standards that are quite high. And with that, we've been able to get over 45 centers around the world, not just in Europe now, but we also have in Israel, we have in Melbourne, and we have one, as I mentioned, also in USA. And it doesn't matter that it's ENETs, it's not that it's European, but what matters is that patients have access to specialized care and to certain standards. And that's what it's all about, really.
Yeah. So ideally, you'd like to have the patient and the carers in the room when we're discussing it. I think they'd probably get a clearer idea of sometimes when the evidence isn't clear of what to do, and when there is disputation about the best course, and have them help us. That's obviously not practical when you're discussing 15, 20 patients in a meeting, or 30 patients to get them all there. How do you communicate the decisions to the patients?
First of all, I think that, individual physicians will present their individual patients, and they're acting as their own advocates. And I think that as patients become more and more aware in our group of the structure of the MDT, they're really well informed about that, and they have the information we'll touch on later. Of course, from the first day that they come in, they find out about the pathways, in fact, and how they're going to be dealt with. And you can't absorb everything in the first visit. It takes a while, and fortunately for a lot of these patients, of course, over time, become very friendly with the group and become real experts, which is great and gratifying, of course. Your point about the advocacy there is important. We have non-physician advocates present at the tumor board. So we have our multidisciplinary nursing group there as well. They're usually the first point of contact. So they will meet the patients, and very often in the clinical visits as well, that they will see the patients first to make sure that that it's not just a medical thing that happens. So it's to try to get a more holistic approach. I think ultimately, in an ideal world, it would be good, I think, to have the patient present, of course. But maybe a development could be that you would have a non-physician, non-healthcare professional advocate at tumor boards. It may exist in some countries, and I think that's probably an evolution down the line. But I do think that in the tumor boards that I've assisted in, and in those that I've visited as well across Europe, I think there's been good representation. How we transmit the outcome like I said, is, we see the patient. We try to do it on the same day so that the anxiety that comes with coming back for a CT scan or another nuclear medicine scan, let's say maybe 10 days before the multidisciplinary meeting, we try to decrease that as much as possible so that we see the patient on the day of the multidisciplinary meeting. And if not, we call them and then we bring them up when it's practical for the patient. But we're there every Friday, so as long as the patient can come back, we try to give that on the same day. To that grey zone always between assessments, etc., is stress-inducing as well.
Dermot, if you're meeting a patient for the first time, how long do you have with them in that clinic visit when you're trying to convey all that information?
We have 45-minute slots for new patients, and honestly, sometimes that's not enough. Is my experience. So what I try to do is that if it's going a long time, I try to break the consultation. Then let the patient off for coffee, go digest a little bit, come back and see our specialist nurse. We have some written information that we give as well, and something that we have to develop better because we're not very good at that. In fact, we try to a bit, so we've got to improve that. But there's always a fine line between oversaturation as well. So I think just having an honest approach, but I think coming back and having a chat with our nurse specialist is really good as well, because they can then really work out what's been absorbed and what needs to be sort of maybe just redefined again.
Okay, so you've heard from us about how we perceive the multidisciplinary process and how we on our side of the desk see it. I'd like to open it up to the audience to have anyone who has any comments or any views on how the multidisciplinary process works or doesn't work, and how we might improve it as the team that do that. And so I think Kate.
Sorry, I'm just going to give the expected disclaimer. Today's just for general information only. So sometimes when you come to these things and you've got all of these doctors held captive on the stage, it's so tempting to ask questions pertaining to your own situation, but we just need to be really kind to these professionals who've donated their time. They haven't got our scans and our blood tests and our pathology results, so they can't give individualised advice. So the other thing I was just going to say is this is being recorded, so we need you to use the microphone. Even if you're shy, please use the microphone so that everyone can hear and that the people who are viewing live can also hear. Thanks.
So if anyone has a comment on the multidisciplinary processes as they've experienced, put up their hand and the microphone will be delivered to you. I see one hand. Thank you.
Hi. Thank you for coming. A question. If when you're first diagnosed and your oncologist or multidisciplinary team are not NET specialists, should they then refer that person to a NET specialist team?
All in favour say aye.
Yes. Yes.
Show of hands.
Yes.
Yeah. We clearly think that with rare diseases that are very complex like this, that the best care is delivered by people who are involved in its care on a daily basis. So I think the short answer is yes. But that doesn't mean that you have to sever your relationship with your family physician, with your oncologist, with your surgeon even. And very much, I think all of us would endorse the view of a shared care model, where it's very important to have good support locally and continuity of support, because sometimes this can be a very long-term relationship and you can't necessarily have all your care in a centre of excellence or by a NET specialist. So getting the team to engage in that shared care model is something that we think is very important.
Yes. Sorry.
I would also, however, say that not everyone can access a large center because geographic reasons and ability and resources and so forth. But I think the field is also changing too. In the old days, where everything is based on expert opinion, without being able to access the experts is a real problem. One of the main reasons for doing definitive randomized clinical trials is to essentially generate the kind of data that we have very high level confidence in, that in certain situations can be implemented by, I would say, non-net specialists, but maybe also very good oncologists. So there's a spectrum there. I think it's always better to come to the large centers, but if you cannot, it doesn't mean good care is not possible.
The model that we use in New Zealand is that we try to have the multidisciplinary team available to everybody, but share the care with the specialist who's looking after that person. Encourage the specialist who might not be a true net specialist to engage as much as possible and try to reduce any barriers for engagement, just because the practicalities is it is really hard to move around the country, and also by doing that, then hopefully that person will become more expert, and then the next person they look after will be better cared for in that. So it's a bit of both, I think. So sometimes it's halfway in between.
So I know that Uppsala for many years has been running a preceptorship for oncologists and endocrinologists and specialists to come and train in the niceties, if you like, the complexities of this disease. More recently, Peter Mac has set up a preceptorship that we hold annually. And so if you have clinicians with whom you're involved, getting them aware of those training and education opportunities, I think is a good thing to do. Any other questions or comments on? Yeah, there's one here.
I'm not directly involved, so this is fairly theoretical, but I think my question relates to that gap between the clinicians' perceptions and the patients' perceptions. You've used the word decision and someone else said outcome. So effectively your group comes to a decision, but I would have thought it was actually a recommendation that would then be put to a patient with pros and cons, and it's their right to decide legally, but is that ever happening, or how often does it happen?
That happens all the time.
Right, good.
You're right as a patient. It is a committee decision, it's a recommendation, but ultimately we give the patient enough information for them to make an informed decision about what they would like to do with their disease. And I tell my patients, we're the navigators, you're the captain of the ship. You tell us where you want to go, we'll provide you with the options and we'll take you there. So it's up to the patient to make that informed decision. It's not for us to tell the patient what to do. That was probably medicine 50, 60 years ago. It's not our current.
Yeah. And often the decision is not a single decision. It's to offer possibly a range of different options for a patient. You could have surgery, you could have somatostatin analogues, you could have PRRT. So it can be a range, and that's where the discussion comes back to the priorities of the patient and their family.
Our MDM outcome document is actually, it says at the bottom, treatment suggestion, not recommendation, not outcome, it's because we often don't know the person, and that's the most critical part of what happens next. Right.
So how do you know if your doctor is dealing with an MDM, like a team, or is he just working on his own?
Ask him.
Exactly.
Okay.
And sometimes it's easier said than done. And I think I go back to also with the how do I get a referral as well. We encourage patients to ask the question. If that's what you feel you want to do, you need to ask the question and try and get a referral too. But yeah, it's about asking the question.
Well, I mean, if you've got a centre of excellence or a centre of expertise, shouldn't they all be working with that centre of expertise anyway? I mean, isn't that the point?
Yeah.
It is quite common, for example, in Israel, that I'm getting emails or phone calls from GPs or gastroenterologists or from the community that asking for our advice regarding a specific patients with NET, because in general our centers are well known as referral centers in each of our countries with expertise in treating neuroendocrine tumors, and it's really a matter of collegiality, to and the ethical problem for a physician that doesn't know how to deal with a NET patient, to ask and to help the patient in a proper way. So usually it's really collaborating. We have seen the patients at least once, and then they are going back to the referral doctor, and we are continuing the collaboration and seeing from time to time the patient if it's needed. So you should ask your doctor if how many patients with NET he or she treated. It's really important. It's your life.
I think that, getting back to that lady who asked the question, I think that the experience that I've had, certainly in both when I worked in France but also in Ireland, is that we still have oncologists and physicians who are dealing with NET and they don't refer for whatever reason. It's rarer and rarer, and I think that what we implemented was that patients can vote with their feet as well, so they can contact us directly. However, getting back to what Rod said, and we've got ways around it of communicating with the physician. We try to smooth that pathway out because they may be coming from a long distance away, just like you were mentioning, Ben, as well. They said they may be coming from South Island and they're going to have their therapy perhaps down there, etc. So most of the time, we're very used to dealing with those difficult situations of communication, etc. But if a patient comes of their own volition, we usually contact the people who didn't refer, and we write to them nicely, etc. and sort of we can smooth that over most of the time, but it does create a lot of stress for patients, honestly.
Exactly, and I think, where the Net Registry of Doctors on our website is one of the key things that we built from the very start to try and direct patients to these experts as well.
Many times I'm telling this same patient that was afraid to ask the doctor if to come to me or not, would you like me to write an email or to call your doctor just to explain, not to be in a not nice situation that you came to see me and you are not trusting him or her. So
I have a question. So we've spoken about how when a person gets referred, they are put through your disciplinary meeting. How often do those patients cycle through? What's the as the years go on, how often do they cycle through those meetings? What's the touch point that brings them back to be discussed? Is it because they go back for another round of PRRT? Is it a particular scan? What's the touch point that brings them back to be discussed again?
I think it's generally where a change in the strategy in that patient that the patient's been following. So if there's a new symptom, change in the scan, new therapy that might be suitable for someone who hasn't had a therapy available for them before. So it can vary, but and sometimes we discuss them just to pat ourselves on the back when a patient's doing well. We like to see that they've come back and we don't need to do anything more. So that's all good. So. I think we might move on to the next session. When we're discussing this, we're trying to make out recommendations to the patients based on the best available evidence. And unfortunately, in this disease, sometimes there are huge gaps in the evidence that are available to us. So we're going on intuition rather than on science. And in that regard, we as a community are trying to do clinical trials. But when I'm talking to patients, I often get the sense that they don't necessarily understand what a trial is and the different kinds of trials that exist. Sometimes doctors don't understand it either. Certainly ethics committees don't. Anyway, it can be difficult. Perhaps I ask Michael, who I think shares my frustration with the Peter Mac Ethics Committee at times, can explain to us the different kinds of trials that exist.
Thanks, Rod. In terms of medical trials, there's 3 different phases when we're looking at a new drug. Often we'll get drugs which have been looked at in experimental animals in laboratory, which shows very strong activity, for example, in a neuroendocrine tumour model in a rat or a mouse or in a test tube. And we're therefore told, well, this drug has great activity, we need to test it in humans. So then what we do is do what's called a phase 1 trial, first in human trial. And in that trial, we're trying to work out what's the safe drug level what's a safe dose to give a patient with that drug? What's the best way of giving it? Is it orally, intravenously, underneath the skin? What's the best way of giving it? Is it once a day, once a week, once every 4 weeks? And the major aim of that so-called phase first in human trial is to really determine what's the safe dose and what are the potential side effects of that drug. Sometimes you get an indication of that, of the way the drug works in animals, and it gives us an indication of what are the potential side effects. But we really need to see, is it the same in humans? And then once we know that it shows activity in patients with NETs, we say, fine, let's get a better feel for, now we know what the safe dose is, how to best give it. Let's test it in a group of NET patients, which we select based upon a trial design, and see what are the response rates. And it might be decrease in size of the tumour or duration of tumour control, or it might be decreasing in hormone levels, for example. And then once we find, fine, it's very promising, it looks very interesting, let's compare it to the best standard of care. And we then go to what's called a phase 3 trial, where we compare our new drug with the safe regimen and the safe dose to the best gold standard of what we had been using before. And that's often a much larger trial, often involving multiple centres, may even involve multiple different countries. And that way we can actually identify, is this new drug, or it might be a new drug combination, is this the new gold standard for us to move forwards with, and then use it as ongoing treatment, as standard treatment for patients. And there's a couple of different types of trials. There's what's called an investigator-driven trial, where as an investigator, I'll identify the drug and come up with the idea, and then we try and go to government or granting bodies, including the Unicorn Foundation, for example, and we therefore design the drug and the trial, and we act as responsible agents for that trial. Other situations, which is more common, we have the pharmaceutical companies, which they have a whole pipeline full of new drugs, and they come to us and say, well, we want to test this drug in your institution or as a network of institutions, and going from phase 1 to phase 2 to phase 3. And obviously the cost, if you're looking at a phase 3 trial, is quite huge, because you might need to test and treat, it might be a couple of hundred patients, depending upon the type of disease that you're treating.
So James, you've led a number of international trials. What are the relative merits of the investigator-driven trials, and societal-driven trials like ENETs running a trial, and those run by the pharmaceutical industry? Many of our sponsors that thankfully support us, that you're here and the patients are here. What are the merits and disadvantages of each of those models?
Yeah, so definitely, often it's a spectrum. Like when we started developing everolimus in neuroendocrine tumors, it started as an investigator-initiated trial. We had to approach several different companies with mTOR inhibitors because we believe they are going to be active, and convince them that it's worthwhile to do this. It's often you start here because most large pharmas actually know very little about neuroendocrine tumors. In fact, they don't have any in-house expertise. They may know something about colon cancer, breast cancer, but neuroendocrine they don't really understand. But one of the limitations with investigator-initiated trial is this concept of health authority. Who do they hold accountable for the conduct of clinical trials? So if you're the IND holder and sponsor of the trial, you are responsible for everything associated with the trial. So that means that with investigator-initiated trial, multi-center trials are really hard to do because it's very difficult for me as investigator to let alone understand the quality of data and conduct in Boston, but across the country, it can be very, very challenging. The other trials, mechanisms, in the U.S., often it is NCI-sponsored trials. So NCI has clinical trial networks, both for early trials and late-stage trials, and they would hold the IND. They will send people out to each site to supervise and look at the data, make sure everything's going okay. And that's another mechanism. With industry-sponsored trial, they often hire what we call CROs, or clinical research organization, where they have in-house organizations that allow them to file essentially what we call IND, or investigator, essentially application to the health authority in multiple countries. That allows them to essentially, in rare diseases, to conduct trial across, say, 70 sites in 15, 20 countries, and get those trials done, a little bit faster, if you will.
So, Halfdan, I'm sort of in awe of you organising a multi-centre trial across Scandinavia, all the Nordic nations, in a rare component of a rare disease. How did you go about that?
Well, I think doing investigator trials now are much more complicated than before. The regulations are more stricter, finance is difficult, and the problem is the thing we really want to investigate, the pharmaceutical industry might not be interested in it, and so that it's hard to do these investigational trials. So you have to manage to get some funding, and then you have to collect them, and so every time you do a trial, you say, I'm not going to do this again, actually. But takes some years up. So,
I'm sure the patients thank you that you continue to do them.
But that is a problem, that we need some alternative financing these very important trials for the patients, not just do the trials the pharmaceutical industry think is interesting. And that's a big problem, at least in Norway.
Yes, so Grace, probably a good segue to talk about PRRT. I mean, we've been doing PRRT with lutate since 2005. We only just had the first randomised controlled trial published late last year, which is probably going to be the impetus to get it funded. But it really just convinced us what we already knew. So there's this problem of levels of evidence. How do you see that playing out?
Yeah. I think it is a very challenging area, particularly doing trials for a relatively rare tumour, although it is actually not that rare anymore. But still, in comparison to other tumours like breast cancer, prostate cancer, you can get a lot of people, patients involved because it is just a lot more common. But for such a rare tumour, which is very complex, and trying to find a homogeneous group amongst such a complex tumour is actually difficult. And to do a good quality trial, you need the numbers, and in this context, you really have to work together with clinicians and other hospitals, for example. It's very, very difficult, even in Peter Mac, to be recruiting patients to be running a very, very big trial. So the way to go forward is really to collaborate, within Australia, and even better internationally with the experts here. But there's huge barriers there, financially, resources.
So the cost of a randomised controlled trial is around having enough statistical power to make a very accurate assessment of which treatment's better than another. So it needs a sufficiently large number of patients in each arm, and each of those arms need to be rather homogeneous, that there aren't other factors that might influence the outcome of one group to the other. And in an intrinsically heterogeneous disease, that's quite a challenge. You may need to reject a lot of people from the trial in order to get a homogeneous group of patients. And at the end of the day, the group of, once you've proven a therapy, the cost of running that trial gets amortised back. The investment that the pharmaceutical company has made in that has to be shared by the patients who get the therapy or the community who pays for it. And so there's a fundamentally different cost of balance in rare tumours than in common tumours. Would you like to comment on that, James?
Yeah, actually, I want to go back just a little bit because I'm actually a big supporter of randomized trials. And yes, these trials are large and often are costly. But if you think back, the prior publications, some of the large series of PRRT, Quackenboom's paper was 550 some odd patients. There was another paper with 1,100 patients. But these were unconvincing to the extent that we have been doing PRRT for decades without it being health authority approved in any country. not in Europe, not in US,
Not in Australia.
not in Australia, but a small 200 patient study, fraction of what of the patient that was already treated, 1,100 or 500 or so, and so forth, can generate the level 1 evidence to get it approved. So it's widely available. It's reimbursed by insurance companies. So these are really needed. More heterogeneous the disease, more it is important to have this. And there's this concept in clinical trial called equipoise. So this is really the health authorities as well as the ethics committees look at in terms of whether clinical trials should be done. And equipoise is not about my belief or Rod's belief or any of our belief. It's really to say across the spectrum of experts, could be across the country, across the world, is there genuine uncertainty about whether the drug is efficacious and should be used in a certain setting, and that's really the kind of ground that essentially justify all this. Now, in terms of cost, I think there's a couple of things. One is it's not just the cost of the clinical trial that drives these prices, which I think is really kind of crazy these days. It's really a little bit too high in my mind. Because what we're really paying for is all the failures. If you look at spectrum of all drugs that goes from lab into human clinical trials, only about 5% of the drugs that enter human clinical trial will ever get health authority approval. So you're paying for the development of the 95% of drugs that don't actually work. That's why the cost is kind of high. And this is but if we do a better job in terms of picking the right drug to developing the right indication, that will also help as well.
So, just taking the example of PRRT that we just mentioned, a lot of the development work was done in academic centres like the Erasmus Medical School and Medical Centre in Rotterdam. They pioneered, developed this therapy. It went out to other academic centres who did it. It's now been sold on to Novartis for $1 billion+. Ben mentioned this is a very expensive therapy for the New Zealand patients to come to Peter Mac. They pay in the order of 30 to 40,000 for an induction course of treatment, 4 cycles of treatment. How much does a course of a cycle of PRRT cost at MD Anderson?
I actually don't know the answer to that question yet.
I do.
But the drug acquisition cost for a single dose of Lutathera in the U.S. is $47,000.
US dollars. They're big dollars.
So about 200,
really
200,000.
Big dollars. So, we have this sort of asynchrony, but that's where I think the patient advocacy groups become very important, because obviously at $50,000 a cycle of treatment, that puts it out of the reach of most patients. If that's just the cost of the drug, ignoring all the other things, the imaging, the consultations, if you needed to come into hospital, everything around that, it makes it a very, very expensive and for many people unaffordable therapy. And so the access issues become really paramount in our minds, I think, as a community, of how we can afford and justify these therapies.
This is a huge issue, cost of medicines in the U.S., but across the world. To the extent, it probably won't address PRRT for now, but all of these drugs eventually become generic. But even now, the generic drugs are still very, very expensive now. So there's actually a group, there was an opinion paper published in New England Journal of Medicine of academic institutions and nonprofits actually thinking about coming together to become nonprofit generic manufacturer of medications. So, get the cost at least once is off the exclusivity and patent protection to a much more realistic level.
Okay. I guess the patients here will be interested a little bit in what trials are currently available in Australia. Perhaps, Michael, in terms of trials that you're aware of in terms of drug therapies.
In terms of drug therapies, we have two trials. One's called the COMPETE trial, which is PRT versus everolimus in patients with small bowel neuroendocrine tumours, which are not secreting hormones, or patients with pancreatic neuroendocrine tumours, whether they secrete hormones or not. And that's a multi-centre, multinational trial. We've put on a number of patients on that trial. And that's for patients whose disease has got bigger over a 3-year period and is suitable for PRT. We have the control NETs trial, which is being funded by Unicorn Foundation, also by the AGITG. And that's looking at the question of what's the role of chemotherapy added to PRT versus to PRT alone. And that's in patients with small bowel NETs and also pancreatic NETs. And we just heard this week that the last patient was recruited to that trial. So we're looking, and I think the international community is also looking forward to the results of that trial. And then there's another trial which is being run through the AGITG, again supported by the Unicorn Foundation, the NABNEC trial, which is in patients with the more aggressive spectrum of the disease, grade 3 neuroendocrine tumours. And we're looking at new types of chemotherapy combinations where patients are either randomised to carboplatin etoposide, which is our gold standard, versus a Taxol formulated, what's called Abraxane with carboplatin. And that's recruiting as well at the moment.
So 2 of those trials involve PRRT. Grace, any others open or opening?
Yep. So there is, in addition to what Michael presented, the COMPETE as well as the control NETs trial, there is currently an active trial that's going called JR11 study. So conventional PRRT is when lutetium, which is the radioactive component, is linked to octreotate, which is the peptide. The peptide brings the radiation to the tumour cells. But with the new trial, with the JR11, we're using the same radiation, so it's lutetium again, but what the difference is that instead of octreotate, we're linking it to a new peptide called JR11. So the JR11 is slightly different to the conventional octreotate because it binds onto the tumour slightly differently, and it's meant to bind on stronger as well as to more of the receptors on the tumour cell surface. And in theory, there should be higher uptake compared to the conventional lutetium octreotate in the order of about 30 to 40% higher uptake. So hopefully the effectiveness would be even better than the conventional lutetium octreotate treatment. And so this is an international, actually, multi-centre trial, which is industry-sponsored. And we've just completed Phase A recruitment, going on to Phase B recruitment, and Peter Mac, as well as, I think, one site in Perth, are actively recruiting patients at the moment. So that's an active trial. But we do have, hopefully, 2 or 3 upcoming trials. We hopefully will be up and running in the next year or so. One of the trials is called LUCAT trial, which is really for patients with higher grade neuroendocrine tumours, with a more aggressive type. Conventionally, these patients with a grade 3 disease would go straight on to chemotherapy, and conventionally is carboplatin etoposide. But we know now with Halfdan's data from his Nordic trial that there's a group of patients who don't actually respond very well to this regimen. And in fact, that group of patients may express somatostatin receptors, so making PRRT potentially suitable. And with our background experience, we have given PRRT to that subgroup before and with very good effect. So what we would like to do is to select that group of patients and then randomize them to having PRRT or another type of chemotherapy, which may be active as well for that group. So that would definitely be a multi-centre trial because we need to get more patients. Most likely, or definitely Australian-led, but most likely an Australian multi-centre trial. We would like very much to extend it internationally, but at the moment it's really getting the funding and the support for that. 2 other trial is one combining PRRT with immunotherapy for Merkel cell carcinoma, and we do have funding for that, so hopefully that will be up and running in the next year or so. And the third potential one is combining PRRT with another drug called PARP inhibitor for neuroendocrine tumor patients. And radiation from the PRRT causes damage, but sometimes after causing the damage, the cells can actually repair itself. And so in theory, by adding the PARP inhibitor, which hopefully would prevent that mending to occur, it may further increase the effectiveness of PRRT. So that's in very early development stage, but hopefully we do have support for that as well.
So, James, are there any trials happening in MD Anderson or US that you think that Australian patients should be lobbying to get here in Australia?
Yeah, so in terms of trials in the US and elsewhere, the larger trials are in looking at some of the targeted agents, for example, that are refractory to standard agents. Cabozantinib comes to mind. We'll be running the cooperative groups. And there's also a similar compound in Asia, in China, that's under clinical trial with sulfatinib, and that's also in a phase 3 development. Beyond that, there's a large number of smaller exploratory trials to generate those initial evidence before we take it to much larger multi-center studies. Many of these are looking at immunotherapy combinations. We're exploring a number of these at MD Anderson, but there are other trials open at other centers as well. And there are some early trials looking at bispecifics and other toxin peptide conjugate. So similar to PRRT, but not with radioisotope, but with a toxin or chemotherapy agent, and those are in early clinical trials as well.
So Dermot, where do you see the role of groups like ENETs and the ENET Centre of Excellence group or network in sort of coordinating some of these trials on an international basis? And do you have a mechanism whereby you can interact directly with the pharmaceutical industry to generate the ideas and support such trials?
Yeah, this has been problematic. We've been successful in a couple of international trials that we've run through different countries, and we can also try to lobby as a group the pharmaceutical industry to try to put pressure to maybe target some areas that are interesting to us. So, in other words, instead of having an investigator-led trial, as was mentioned earlier by Michael, so that means us with a clinical question. We want to ask a very important question that may not be very interesting for the pharmaceutical industry to support. So it's very difficult to conduct these clinical trials. And we just finished recruiting in one trial that was very hard to fund. And in fact, Novartis did fund it, but there's no funding of sort of an international group like ENETs or NANETs. In fact, what happens is that to have an individual trial, you have to have a sponsor in a local university usually, and this occasion it was actually financed through a group in Barcelona. So one of the universities in Barcelona, from one of our chief investigators who was part of our group, they ran it through Spain basically. And the same thing might happen, for example, if we try to do it with Halfdan or with Rod or with James or wherever. But it's really hard to steer a pharmaceutical industry to support trials that are very, very expensive, that are not really going to be useful for them. They have supported traditionally smaller clinical trials, for example, testing drugs in what was referred to as a phase 2 trial. Sometimes we get support, just like you have here in Australia for various different initiatives. But to support big ventures in phase 3 comparative trials is very, very hard. One mechanism that we're looking into is to try to lobby through the European Reference Network, which is a European Union body looking after rare diseases. And within the rare diseases group in the European Union, there's a subgroup looking after the rare tumors, and neuroendocrine tumors come in within that subgroup. But up until now, there's been no specific funding. So, like here, probably like everywhere else, we are looking at lobbying to try to direct that. And it's certainly a huge unmet need for our community to be able to set up clinical trials that would be, in a sense, pharmaceutical independent as well. So it's thankfully we've had some really, really important trials that have been sponsored and sort of initiated by the pharmaceutical industry. But there are many others, in fact, that would be that we'd like to do that. It's sort of pharma independent, but it's very difficult.
So Many people in this room will have heard of the Medical Research Futures Fund, which is your taxes at work. We had an introduction in one of our budgets of a co-payment for patients seeing their doctors. There was a big outcry about that, and the decision was not to take it away, but rather to put it into a future fund to fund research, particularly medical research. And one of the recent calls was for rare diseases, and the study that Grace mentioned in Merkel cell carcinoma has been funded by the Medical Research Futures Fund. It's a $20 billion fund, will be, and give millions of dollars of extra to research. And so that's really a question for Simone. When are we going to have patient-led, rather investigator-driven clinical trials? How do you see Inca, as President of the World, becoming active in leading trials and getting funding for these things?
It is definitely something that we speak about a lot, and we had a lot to do at a national level with lobbying for the Medical Research Future Fund to look at rare cancers, because we needed more government funding, and that was definitely something that we really pushed here. From an international perspective, we're looking at all different things, because we know that even at INCA we can't rely on our industry partners for everything. And is it philanthropic? I mean, we've had some success. The Net Research Foundation had a huge success with philanthropic donations. We've seen crowdfunding for clinical trials through the eye cancer oncolytic virus, which Professor Schalloberg heads. So we've seen that sort of funding as well. But not all of them are sustainable. So we absolutely rely on the patient voice to show what the issues are, especially in the rare cancer space, and how can we make, for us in Australia, the NHMRC, take notice that we need to do clinical trials differently. We need randomised clinical trials, but I think here the government is actually understanding that we're not going to get the large numbers. But how can we be clever about the trial design to get more trials going in smaller numbers, but that still produce really important evidence? So it is an ongoing question, and it's something that I know our patient organisation groups in the UK, in America and everywhere are really pushing FDA, or for us it's TGA, to really start looking at the different funding models for rare, and being more effective that way, but also looking at sustainable models for greater funding, and government stepping up to the plate as well, and using our money more wisely in that space.
Yeah. So when we look at outcomes of randomised controlled trials, perhaps I'll ask Michael this one. We look at Kaplan-Meier curves, which basically either people progressing on a scan or dying, and we compare the slope of those two graphs, treatment A and treatment B, and the less steep the slope of that graph, the better we think the treatment is. But every one of the little dips down is an event. In many cases, the death of a loved one, who's part of a family, and everyone under the graph is still alive, but we don't know how they're living, what the quality of their life is. And so increasingly, our focus, I think, as a group has to be on the quality of life, not only the duration of life. And so tell us a little bit, Simona, about patient-reported outcomes and how important they are in these trials.
I think that are really important, because this is what really matters at the end of the day, the results that are reported by the patient. I mean, in terms, if I would like to address the topic of the trials evaluating somatostatin analogs, for example. So we are looking at the improvement of the symptoms reported by the patients, improvement in quality of life. So we know from these trials that patients that are not controlled with the treatment, they have a lower quality of life, lower survival. So this is really important.
Okay. We've said a lot about clinical trials. I'm sure there's lots of questions about clinical trials. People have been involved in them, how to get involved. Any questions from the audience regarding those?
I was just wondering that obviously there's a fair amount of global collaboration about NETs, but does a MDT and do clinical trial groups get to a point that they say, we've seen this patient over and over, let's talk to another country, get their advice, because, you know, we've got to the point that what else do we do? And the same with clinical trials. If you're saying maybe there's small numbers of specific requirements for that trial, is there the ability for patients to be able to access trials that are available in other countries? Obviously there's funding issues and that sort of thing, but from patients' point of views, you know, treatment, part of like MDT collaboration globally and also clinical trials globally, is that something that is offered or you see being offered to down the track, or is it available now?
Perhaps I'll open. One of the things I feel most proud of setting up in the Unicorn Foundation is our Research Advisory Board, which is not populated by people in Australia, but rather by international experts, to help us set priorities of the kind of research that we should be doing here, that we could be doing here, and whether you know, they're not going to fund it, we've got to find the funding and do it here. But it takes away that sort of you know, narrow focus that we might have living in a small pond, getting experts in the big pond. But nevertheless, you know, it is an issue, and I think we're very fortunate, I guess, because we all know each other and we know lots of other people in the field, that we will very regularly send off pathology or scans or just a synthesis of the case of a difficult patient to experts in the world. You know, Simone's sister, Kate, went off to Uppsala to see Kjell Oberg, who was the first person that I ever met in the neuroendocrine world, you know, before I knew that anyone else was interested in neuroendocrine tumours in the world other than me. It was kind of nice to meet him. And he's become a great friend of Australian neuroendocrine, as he is in, I think, all the countries of the world. And so this is a small, close-knit society, actually, and many of the players in it do have international contacts. We have APNETs now, members from, I think, 10 countries in the region. One new member of our APNETs Council in the back there from Bangladesh and from Dhaka. And we have, you know, really an incredible community of people. So yeah, I would say yes, we do. It may be sort of kind of opaque to the patients themselves, but we do rely on that network. You know,
Did anyone want to mention about the travel? Because we have to manage expectations about patients feeling that they have to go elsewhere because we know that we're having that contact.
Yeah, I mean, I think that it, you know, it depends. So some patients will request it, and like as Rod is saying, sometimes you just feel, you know, we talk about this heterogeneity, which really means it's so different. So the same patient with the same type of tumor in the small bowel with disease on the liver is behaving differently, and you think that maybe you've seen this before, and then suddenly you find that it's behaving in a strange way. So getting the opinion of somebody else, it comes fairly easily to most of us, in fact. So it's good to get the opinion of our elders. We sort of say someone like Kjell, who's been down that road. Martin Kaplan was telling a nice story about a patient with very oddly behaving functional tumor with vipoma that was just not behaving to the usual therapies, all of the therapies that they use. In fact, he phoned one of the elders, and the elder said, try some steroids, you know, and the patient was dying basically in the intensive care. And it was that little phone call, in fact, which took 5 or 10 minutes, that was life-saving. So there's great sharing within the community. In terms of travel, in Europe it's a little bit different because we can criticize Europe for many different sort of between countries and stuff like that, but we do have patients have a right to travel. There's a cross-border directive, so that patients have a right to be treated in different countries, so they can go and it'll be funded. We also have, in our country, we've got a treatment abroad scheme. So for PRT, like in New Zealand, we don't have it. So patients travel to a recognized center and they get fully paid, okay, for the travel and also for the treatment. So we're really, blessed to have that, if you like. The other thing is that if they go for clinical trials, we've been sending some patients as well to populate some rare clinical trials to other centers in Europe. And we've been lucky also to be able to get that across the line as well. So our government will help us with that as well, if the treatment is actually indicated. So there is sort of good cooperation in some countries, and Europe has facilitated that type of program, that's for sure. So we're adhering to the guidelines. And just to reiterate what Rod said, I think that the NET sort of specialists, they're pretty open to sending people for a second opinion. Well, that's our experience anyhow. And if we can, I know that, for example, James might comment on this, but the sharing of patients for different clinical trials in the US has always been really, really proactive, I would say.
My question's directed at Dr. Lawrence. There has been no history of cancer in my family, and it obviously started with myself. And I'm just curious about the genetics of NET tumours and whether or not there's ever been any research done on genetics, and whether or not I would have to have my children tested in the future and so on.
That's a good segue to the next section.
Expert genetic landscape.
And quite a hard question. So sort of going back a step, if you think about what cancer is, you have to think about how a normal cell works. So normal cells are our body's made up of cells, and so made up of about 40 trillion cells. And in most of those cells is this little control centre called a nucleus. And inside that nucleus is a whole lot of DNA. And it's organised into 20,000 genes. And each gene, which is in each of these cells, is a recipe for something that the cell does, like grow a bit, stop growing, become a toenail, an eye, or something like that. And cancer happens when you get mistakes in those genes, not just any old genes, but probably it narrows down to a few hundred, which are important for something that the cell does that's fundamental to growth or staying in its place and not travelling to another part of your body.
Or not dying.
Yeah, to live at the cell being able to continue to live forever, whereas normal cells don't. Normally cells die after they've been multiplied a few times, or certainly no more than about 60. So when we think about the genetics in cancer, we can think about it in two ways. Firstly, is that during your life, every time a cell in your body grows, it has to split into two. It doesn't just get fatter and fatter and fatter all your life. It splits into two. And the amazing thing about that is that it has to copy all of that DNA every time it copies. And inside each of those 50 trillion cells is 5 billion pieces of DNA code. And it's constantly dividing and copying all through our lives. And cancer roughly happens when you get mistakes in that copying. And sometimes if the mistake's in a gene that does something to do with growth, it will matter. So when we get a piece of cancer, we can actually find out what those gene mistakes are by looking inside it. And so for each of you that has a neuroendocrine tumour, that information is actually already available in your tumour, wherever that is. So the little biopsy or the surgery or the piece of tumour that led to your diagnosis actually has these cells with these nuclei in it, with this DNA code that's got the mistakes in it. And so we can look inside it and decode that. And the hard part is knowing what to do when you find that information, because sometimes it's not straightforward. Now, coming back to your question, is that we inherit a copy of our DNA, half of it's from our mum and half of it's from our dad. And if one half of it has got a problem, got a tendency to cancer, then does that predispose you to get a neuroendocrine tumour? And we know that sometimes it does, and it's probably up to the most recent studies are suggesting about 20% of neuroendocrine tumours of some organs are heritable. Tends to be the cancers that pop up when you're younger, or if you have a cancer that's multifocal, so occurs in more than one part of your body, or if you've had another type of cancer and this type of cancer, or another type of growth and this type of growth. So often there's these signals that tell you that it's more likely that you've inherited this cancer, and therefore, coming back to your question, that you could pass it on to your children. So probably the answer is that about 80% of the time, your children aren't at any particular direct increased risk, although we're never really sure. So we tend to say that you should start thinking about, that your children should start thinking about awareness of cancer and taking part in screening programs for other cancers like breast cancer, cervical cancer, bowel cancer, because they have a statistically slightly higher risk of cancer. Even if you know you have a risk of ENET, it's quite hard to do something about. Now, there are some very specific cases where that's not the case, where it's very likely to be inherited. Actually, Simona gave us a great talk on those in this conference. So there's things such as MEN1 syndrome and some other syndromes which your oncologist or your specialist will be able to tell you about, because they come with clusters, and there's lots of different ones. I don't know if you wanted to comment on that, Simona, but for example, if you have MEN1 syndrome, the first thing that normally happens is that you get a high calcium level, which is one of the salts in your blood, and that can cause gallstones and things like that. And then you tend to get neuroendocrine tumours later in your life. So there's sort of some other warning signs. So your physician can put that together somewhat. So for you, from the story that we heard the other day, it's probably less likely.
So, Ben, I guess a lot of people in the audience, genomics is sort of like a black box, very complex. The whole Human Genome Project, which was announced with great fanfare, a couple of decades ago now, was going to be the answer. That was, for those of you, if you're looking for an analogy of what the Human Genome Project was like writing the telephone book. So you had a number, you had an address, and you had a name. And how much does that tell you about the population? Doesn't tell you very much. The next phase of it, I guess, was the Cancer Genome Atlas, which was like ASIO's file that told you which of those guys were the bad guys and which were the bad numbers you don't want to have in your directory to some extent. But we still didn't really know how these genes, even when they are so-called pathogenic genes, that oncogenes or tumour suppressor genes, how they impact on the course of a cancer or what therapies we should use. Did you want to comment on that?
Yeah, so the concept in cancer care at the moment, and it works in some cancers and doesn't work in others, is that if you know the exact gene mistake, you can match it to a drug that targets that exact mistake and switch the cancer off so it stops growing. And there are some cancers where that works really well. In neuroendocrine tumours, we haven't got there yet, and they seem to be controlled by much more complicated processes. But that's not to say that we should throw up our hands and give up hope in that. When you think about all of the parts of neuroendocrine tumours that we do understand, that's things like chromogranin A or somatostatin receptors, which is the little receptor that your octreotide or lanreotide or PRRT binds to. All of those things were discovered in a lab at some time in the past, and often not that far ago, but usually it takes quite a long time to take the biological understanding to change what we do in clinical practice. And with genomics, which is the name for when we study all the different genes together all at the same time, it's pretty early days. There's been some good wins for some types of cancer, but for neuroendocrine tumours, we need to study it more. And what I think one of the ways moving forward is that if we could get access to if we could build a registry, so that's a list of everybody with neuroendocrine tumours, and then we could find out what happens to each of those people, so each of you, and you to have treatment A, and you respond to it, but someone else responds to treatment B, even though you have what seems to be the same type of cancer. Why is that? And we can then go back to the tumour, look inside it, and match those gene changes with that exact outcome. And so Simone and the Unicorn Foundation are leading a project called the Planet Registry, which will record information, and then there'll be the option, clinical information, then there'll be option to match that to the tumours in the future for this study. So I think give it time, let it unfold. These are really complicated things. Cancers, I think it's no surprise that cancer's complicated. We've been trying. Sorry? Worldwide? So the Planet Registry is going to be Australian. So
at this stage, we hope it might go out. Ben or Simone alluded to the NetRF, the Net Research Foundation in the United States has recently funded a project that we're doing in partnership with Ben, looking at, instead of individual problems or differences, comparing the genetic nature of responding and non-responding lesions in an individual patient in such a way that we can try and work out, because your genetic code is your genetic code, why some patients respond extremely well and others not, and some deposits respond extremely well and not to given therapies. To look at the genes that differ between those may be a simpler solution than maybe trying to decode the whole phone book. And so one of the challenges in that is that we're asking our patients to subject themselves to rather nasty interventional radiologists who stick big needles into them. They're as kind as possible, but they still need to do it. And so it's really helpful to us as a community to get access to tissue. We're trying to develop new ways of doing that less invasively by doing things like circulating tumour DNA, which is little bits of DNA that's shed into the blood by dead and dying cells, which is quite an exciting area of development. But at the end of the day, giving consent to have your tissue tested is really important. We're really getting close to the end. If there are any pressing questions from some of the thing,
My physiology is a bit rusty, but if neuroendocrine cells are involved in things like the stress response, is anything being investigated, any trials on whether stress has played a part in this, why it manifests in the lung in some and the bowel in others, and is any kind of collation of patient backgrounds, what do they all have something in common?
Yeah, I mean, that's one of the pressing questions, why we're seeing this increase in incidence throughout the world, why we see different patterns of disease in different populations, particularly in the Asia-Pacific regions. There's different kinds of neuroendocrine tumours which predominate. What are the risk factors? What are the social factors? What are the environmental factors that determine what cancer you get and how it behaves is incredibly important. The only way that we get that information is by having really deep information about patients, about where they live, how old they are, when they get their tumours, what kind of tumours they are, what grade of tumours they are. And that's why it's good to be in a multidisciplinary environment, because that's where that kind of data is collected. So you're absolutely right that we need to do that. One of my passions is to try and get linkage of the medical history with the big data that exists about you. Every time you go to the service station and you use your flyby card, or you go to your bank and you pay your Visa bill or whatever else you do, there's an incredible richness of information about your lifestyle, what you eat, where you exercise, where you travel, where you live, and all of those things are gathered without your consent, without your knowledge, but they're not used for good. Most of the time, they're used to determine when they bring down the price of petrol or what goes on special at the supermarket in a given time or place. But it could be used for good if it was integrated with medical information. So it's quite controversial at the moment. My health record, everyone's worried about privacy. But at the end of the day, if we don't share our information about our health and about ourselves, as long as there is privacy protections and it's not used for nefarious means, it's going to help us all to deconvolve those really important questions, particularly in rare diseases where it's very hard to do these clinical trials. You're the computer nerd, James. Perhaps you'd comment on big data and integrating that with medical data.
Yeah, it's a big challenge. Nowadays, I think the technical aspect of generating a lot of data is not really the challenge. The challenge is really making the data informed. In fact, If you recall from the a great poet, T.S. Eliot, early in the 19th century, he wrote, where is the wisdom lost in knowledge, and where is the knowledge lost in information? And you can go a step further. Where's the information actually lost in the data, and so forth? Because if you think about it, we have few low-hanging fruit disease where there's one gene, one phenotype, and those by and large we know already. But then we're left with essentially gene-gene interactions, gene-environmental interactions, so many degrees of freedom. If you look at 300 genes, with any 300 points of variation, there's like 3 states in those genes, you have defined more possible humans than there are known atoms in the universe. So really, you need a lot of data, and you need a lot of validation, and very smart people like our friends across the ocean to really make sense of all that information out there.
I've seen online there was a variation on PRRT where they're trying to use alpha waves to attack tumours instead of the PRRT using beta waves. I think it's a trial by Alpha Medics. Do you know much about this and what it looks like?
So PRRT is related to particles rather than rays. The particles go a very short distance in tissue, and as they pass through tissue, they deposit energy. The beta particle is basically an electron, which has very little mass, and so it goes quite a long way. My analogy is boys throwing rocks. These are hand-sized rocks that can be thrown quite a distance, and it's only when they interact with matter that they cause damage. And the matter that is important to the effectiveness of that treatment is the DNA, which it breaks, or sometimes it hits other chemicals, which sets up these things called oxygen-free radicals, which chemically damage the DNA, but the target is the same. It's a breakage of DNA. Depending on the type of radioisotope is the size of the rocks. Some of them are bigger, and so they don't go quite as far. Some of them are very light, and they go a long way. And where they hit is dependent on the energy of that particle, and necessarily you need a cluster of those cells throwing out these particles in all directions, something we call crossfire effect. So getting a whole lot of boys in a field throwing rocks at each other, they cause themselves some damage. If they're on their own, they don't cause much damage at all. The alpha particle is basically a helium nucleus, which is vastly heavier than an electron, so it goes only very short distance. In fact, most of the time it's absorbed entirely within the cell in which it's concentrated. And it's very heavy, and it just bumps into the nucleus of that cell and does a lot of damage to the DNA, which is great if there's 1 or 2 cells, but every cell sort of needs to have the target on it. And one of the challenges that exists with these tumours is that not every cell has a somatostatin receptor, so they don't necessarily get any radiation from the alpha particles. We actually think that probably a combination of both is necessary. The thing that we can't treat with beta particles very effectively is the single cell or the single cluster of cells from which patients relapse, but it doesn't nearly as effectively treat the big deposits, except the ones within the big deposits that have the target. So we may actually eradicate the targeting cells and only leave the non-targeting cells as the ones that will grow back. But we might have other strategies to deal with that. So yes, we know a lot about it. We're doing a lot of thinking about how we might combine them with chemotherapy, how we might combine them with beta particle therapy, and it is an exciting area. We spoke about it in the last session today about the using different kinds of particulate radiation as part of PRRT.
One last question, and I know then everyone will probably want to get off to tea break.
Thanks, Simone. Just a very quick comment on the updates for grade 3. Can that perhaps be covered? Thank you.
Yeah, Halfdan. Yeah.
Well, there is this new group, this NET G3, which we didn't really know about much before. And the prognosis is much better, and treatment completely probably different than the more aggressive one. So it's important we get some more data on these patients and learn more about it, but you have to have the knowledge to treat them different. At least that's one of the new options. And we don't really know if it matters outside the pancreas, because the NET G3 is mainly based on pancreatic patients. There is some. What happens is probably if you have a small intestinal or pancreatic, it's a G1 and G2, and over the years it turns out to be a G3 probably, we think. We don't really know what happens during this process, but it's much more difficult to treat when it's a G3. Yeah. And there's also some more data now that the small intestinal, many of them might turn up to be G3s if you take a rebiopsy in a late stage. And those are very difficult to treat at the moment. So I was just writing some notes actually how to try to get some more data. Yeah, but then we have to cooperate more on these patients. So that's an interesting group because it's the middle. It's between the aggressive and the very indolent diseases.
Okay, thank you very much to our panel for giving up their time, coming out on a Sunday afternoon before their flights back to their various countries. I gather still a beautiful day out there, and hopefully they'll get to see a little bit of Melbourne. But we hope it's been useful to you all to hear the international experts' opinions, and it's certainly great that you're all here. We wish you well in your deliberations this afternoon, and thank you for your attendance. Thanks very much.